Next speaker is an eminent surgeon. He is Professor Yahia Balbaa. He is a well-known surgeon among the Egyptians and the Arab countries. He is going to talk about when should open heart surgery be postponed.
First of all, I would like to thank Dr. Adel and Dr. Fawzia for inviting me to this meeting. It's been several years that I was wishing to attend this meeting. I'm proud to belong to Cairo University Faculty of Medicine, the Qasr al-Aini Medical School, and this is the way I like to present myself, although I bear a number of other titles. This is a painting of an anatomy lesson in my School of Medicine in 1829. When Dr. Fawzia called me, as soon as I hear her name or see Dr. Adel Abdel Fattah, I remember the good old days. The days when we had a department that was standing like a family, everybody caring for patients, everybody caring for each other, everybody working relentlessly, sometimes day and night, just to do their perfect work. I cannot speak in an anesthesia meeting without presenting my specialty. I think we surgeons somehow are anatomically different. When Dr. Fawzia called me for this talk, I had 4 scheduled open heart cases, and on that day, when I received Dr. Fawzia's call, I just had 2 cancelled cases that were postponed. So when she asked me for the title, I immediately told her I already have a title. I would like to speak about when should open heart surgery be postponed, because this was a very long discussion with the anesthesiologist, and it was not easy to reach a decision in every one of these 2 patients. So I chose this title, and I think it wasn't the right choice. It's a difficult subject. I would like to start my speech by presenting to you my first shock in cardiac surgery. I had a young girl, 5 years old, back in 1984, when I was a resident for only 1 month or 2 months. And I had this lovely, pretty girl, 5 years old, with tetralogy of Fallot. And she became my friend for a month. Then she went into surgery, and she died on table. And I went back to where the doctors sleep, and I started crying all night, and I really thought of changing my specialty. Then in the morning, I called my great teacher, my father, my mentor, my idol, and I cried to him. So he just asked me one question. Was that avoidable? So I went back to think whether it was or not. And very early in my career, I started to have a distinct separation between avoidable mortality and morbidity and unavoidable mortality and morbidity. And I had my first quote, and maybe my only quote, that it's true that unavoidable mortality is very painful for everybody, but avoidable mortality is a crime. When Dr. Fawzia called me, as I said, I started to review the literature and see if anybody else have studied this subject as a whole subject. And I realized that it is very rarely reported as such a subject, and that we maybe need one whole conference to discuss when to should open heart surgery in Postponed. I found only this study in 2011 done in Greece, in one hospital, to study why their patients were postponed. And most of the patients were postponed for logistic reasons, unavailable surgeons, unavailable operating rooms, and for some medical reasons. We cannot forget, everybody cannot forget, as Professor Dr. Ali said, that everything is focused about the patient, about my patient. Surgeons, anesthesiologists, perfusionists, intensivists, nurses, workers are there as a team to serve the patient, to have an outcome that has safety, supply safety for the patient, and give quality service for this patient. And as Professor Ali stressed, safety is our mission. And here I'd like to present another quote of my mentor and teacher, great father. He always said, I may not be the best surgeon in the world, but I am definitely one of the safest. And he definitely was one of the safest. One of his priorities in doing surgery is to be safe. Safety begins with the teamwork, because everybody has to collaborate for the same purpose, for the same patient. And the way I see our surgical team is exactly the way I see the musical orchestra. It's just a team. To the extent that when I was recognized for doing a minimally invasive minimally invasive mitral valve surgery in Egypt for the first time, and I was invited to television, I insisted to have the whole team with me, even the nurse. I said, if I don't have the whole team, we operate as a team. If I don't have the whole team in the TV program, I will just cancel it. When I started to think about how should I present, when should open heart surgery be postponed, I thought it was the easiest way to go by checklists. If we have a group of sequential checklists, that's where we can identify patients that have to be postponed. And these checklists regard the structure, the operating room, the intensive care, the personnel, and the features of the patient, whether clinical, lab, or radiological, or the other. Professor Dr. Ali mentioned to supply best care for the lowest price. Maybe in the United States this is true. Maybe in the United States this is applicable. But unfortunately, in our culture, if we target lowest price, quality is compromised. So I would never advise my students or my colleagues to search for lowest price. Maybe in the States there is a minimum standard, you cannot go below. But if we target lower price in our culture, some things are compromised. The OR checklist in Egypt is maybe different than the OR checklist in the United States. Last week, we had to cancel surgery in a private hospital because the power supply, the main power supply went down and the generator was not working. And the UPS of the operating room gave 1 hour instead of 3 hours. So we had to cancel surgery. We have to check every time for the air conditioning, for sterilization, for the health of the anesthesia machine, for the presence and function of the intra-aortic balloon, for the instruments, for the blood gas analyzer, if it's functional or not in my university hospital, for the ACT machine even. Unfortunately, in our culture, there is a saying that is very dangerous. In Arabic, it's الشاطرة تلزم برجل حمار. And I found it in English, does exist at the same proverb. It says, a bad workman blames his tools. I think in surgery, this is not true. Because a good workman has to have good tools. Otherwise, this guy wouldn't have his own rackets to win his championships. Otherwise, Tiger Woods would have played with any sticks. So I think that a good workman needs good tools. And this is why I personally, since the very start, since I started to do surgery, I have my own instruments, my own surgical instruments. And I advise every single younger colleague to own his own instruments, and even at the expense of his food. Then there is the personnel checklist. We have to check that there is the adequate number of personnel in the OR. It's not acceptable to have a surgeon operating without an assistant. Unfortunately, in some hospitals, one anesthesiologist is giving anesthesia in 2 operating rooms. The issue of who is giving the pump, who is the perfusionist in the room. We have very few perfusionists left in Egypt. Some new perfusionists are being prepared as perfusion technicians that may be ready in a few years. And for the time being, some heart-lung machines are run by surgeon residents, are run by nurses in some hospitals, are run by technicians who did not study in other hospitals. So this is unfortunately an issue. I know this is a different standard than you were discussing. Only two types of people should be allowed to work with the patient. Either fully trained individuals and fully supervised trainees. So sometimes we have to postpone surgery because these doctors are not ready. Last week, we had to postpone surgery, cancel surgery at Cairo University because one of the OR nurses died. So we had to just cancel the day because it was inhuman to let her colleagues scrub on the same day of her death. When I speak about trainees, everybody has the misconcept of the learning curve. And some surgeons and some doctors get the word learning curve as a meaning of I have to kill patients to learn. And this is a culture, fortunately not with the majority of surgeons, but some people misunderstand the learning curve is to harm patients until you learn. And this is not true. Because I recall, as a resident or an assistant lecturer, a young assistant lecturer, on one day, I was scheduled to operate a double valve replacement case. So I was so happy and so flattered, my first double valve replacement. And then I pick up the phone and I called my mentor, my father, my tutor, and I told him, tomorrow I'm going to operate a double valve case. So he told me that if people have to die so that you learn, it's better that you don't learn at all. In the old days, training in surgery and in anesthesia was by apprenticeship. You watch someone clever doing the thing, you assist him for some time, then he assists you for some time, and then you do it alone, and then you teach it to other people. This system was very successful, but it was very tedious. Today, fortunately, training has become much simpler. In the other room, there is a simulation lab for transesophageal echocardiography. These trainees don't have to introduce probes and do manipulations in patients to learn. You can learn in skills labs, in wet labs, in animal labs, so that when you go to the operating room for the first time to touch a patient, you can give him quality care. I was speaking to one of my younger colleagues, Dr. Yahia, outside, just a few minutes ago, and I told him that I believe that if you are not handicapped, you can learn anything. I have had this classification always. I believe that a very minor part of surgeons are really talented, and they are very rare. You see one every few years. And a minor fraction of surgeons are handicapped, but most other surgeons are the same. And the level of service and the results depend totally on training. Recently, I read this book. It's a very interesting book that I recommended to my daughter and to my younger colleagues to read. It's called Talent is Overrated by Jeff Colvin, and speaks about how anyone can spend 10,000 hours of his life, which is equivalent to about 10 years of his life. It's called the 10-year rule. And you can reach expert level in anything, even art. Dr. Polk has summarized the attention to detail in the surgeon's life is that if you take care of all the minor details, this is the only foundation for a good surgical result. To move to the next checklist, which is the patient checklist. It will be checked for all these factors. I don't want to enumerate because they are all in books. I would just like to point about febrile illness, which was discussed earlier. One of my patients was admitted to the hospital 4 times. A young boy with calcific aortic stenosis. The night of surgery, he develops fever, 38, 39, normal CRP, normal leukocytic count, feverish, says that he has a sore throat. We send him home. He remains normal all the week. He comes back, admitted to the hospital. The night of surgery, he gets fever again for 4 consecutive times. And it turned out that he had psychogenic fever. With the panic of surgery, he got psychogenic fever. Of course, the history of the patient is important. I would just like to stress the few parts that need to be discussed in your next conference. We have still a controversy about when to stop concentrated drugs, aspirin, Plavix, and the other antiplatelet drugs before surgery. History of peptic ulcer or reflux, I have included this because recently I have been doing upper GI endoscopy for every patient who has history of peptic ulcer or reflux. And interestingly, I found some bleeding ulcers with minor bleeding that warrants to postpone surgery for a week or 2. Malignancy should be looked for because once we have malignancy, we have to answer the question, what is the life expectancy of this patient, and is the surgery we're going to do life-saving or to give him a better quality of life for 6 months or 9 months, maybe it's not worth it. History of amiodarone intake, because amiodarone intake preoperatively for a long time precipitates, increases the incidence of ARDS in post-operatively. The lab checklist, when I was looking, I was amazed to see that in all references, a pregnancy test is mandatory for every childbearing female going to surgery. I didn't know that. Is that standard? We still don't do laser swabs as a routine for all patients, and I think we should. In the last few months, we have had a very long, tiresome debate about what to do with diabetic patients with normal blood sugar and an increased hemoglobin A1C above 8.5. And we don't find any consensus in the literature what to do with these patients. Because if those patients were plastic surgery patients, they should be postponed for 3 or 4 months until they have a normal hemoglobin A1C. But for coronary patients, we still don't know what's the best solution to, and we need your help as a society. Hepatitis markers and HIV have not yet become routine lab in all hospitals. I have included TSH in my preoperative workup because I have encountered one case of undiagnosed hypothyroidism, and this lady died. Blood bank checklist. Sometimes we postpone surgery because there are no blood products available, especially with the rare blood groups. Imaging checklist. All patients should have a chest X-ray and an echocardiograph. I have added to my checklist abdominal sonography for all diabetics. I have added to my checklist upper GI endoscopy in case of history of peptic ulcer or suspicious liver disease or residual liver disease. And I have postponed one patient because he had very severe that were almost bleeding and they had to do injection. And I postponed another patient because he had an active gastric ulcer, which was not apparent clinically. Consultation checklist. Some of our patients need to be seen by other physicians. I think everybody should have a preoperative anesthesia visit because this is not yet routine everywhere in Egypt. We do ophthalmology consultation for all diabetics, urology consultation for advanced prostate disease, and nephrology for heart functions. And then one of the important things that can postpone surgery is failing to have an informed consent by the patient. In our culture, it's not always possible to get an informed consent from the patient because we do not give all information to the patient. Sometimes we give all the information to the family and we give a milder version of the story to the patient. Dr. Ali has discussed giving best care with the least cost. Some of the tests that I have added to my preoperative evaluation are maybe not cost effective. Because in the guidelines, we do carotid duplex study to every patient who is above 60 or has a history of TIA or stroke, and you don't do the rest because it's not cost effective. But I have had one patient, Yahia Balbaa, who was 55 years old, without history of stroke, without any TIAs, and post-operative, he had a stroke, and retrograde, he had a carotid duplex, where he had 95% stenosis on one side, and 90% on the other side. So the question I want to ask, how many patients you need to treat to think it's cost effective? I think it's cost effective if you save one patient every 100,000 patients. Because if this patient was my brother, I would think it's cost effective. We have agreed that the decision to postpone surgery is not always easy, and it's a delicate balance between safety and urgency. The problem is, who will postpone the surgery? We still have this problem. Will the surgeon postpone the surgery, or the anesthesiologist postpone the surgery? We agreed that we all work as a team, and we definitely work as a team. And to work as a team means that together everyone achieves more, and together the patients get better care. But definitely, we need a team leader. Although we are a team, there should be a team leader. And the surgeon is the team leader because he carries all the responsibility. So everybody has to discuss, everybody has to advise, but in the end, the surgeon is the team leader. And the team leader, in the lower concept, not the boss. I mean, he's one of the team that carries a big burden with the rest of the team, carries all the responsibility, and not the boss. The other question is, when? When should surgery be postponed? If we fulfill all the checklists the night before surgery, and the patient is informed the night before surgery that there is no surgery tomorrow, it's very different than having a patient shave and scrub and then postpone his surgery. Because sometimes we think of what we like and we don't think of the impact of this decision on the main person in the center of attention. Speaking about mistakes, we do mistakes. We are human and we have to do mistakes. And the saying by Warren Buffett is, it's good to learn from your mistakes, it's better to learn from other people's mistakes. Otherwise, according to Einstein, you are foolish. We have a problem in the medical culture that because we are afraid of liability and lawsuits and reputation problems, we tend not to speak of our mistakes. So the rest of our colleagues are losing a great opportunity to learn. I found this talk on TED Talks by a physician called Brian Goldman, who works in Canada, and it's a lovely talk about doctors are human, doctors make mistakes, and if we can find a platform, a safe platform, to share our mistakes, maybe not everyone has to repeat them again. As a resident in Qasr al-Ain School, I had a friend who was the worker in the clinical society, the worker who cleaned the clinical society. So he told me that there is one magazine that arrives to him packed all the time and nobody is reading it. And it was the New England Journal of Medicine. So every week I would go to Al-Ain, take the issue of the New England Journal of Medicine and look at one part of it. Every issue there is a case report, frequently about a mortality or a morbidity, with all the surgeons, anesthesiologists, pathologists, intensivists, physicians. All the discussion is written, and I have learned that this is how people learn from other people's mistakes. So I got this idea, and I spoke to my professor, Dr. Hussein Gafar, who was still the new chairman to the department, and I told him, sir, I have a suggestion. I think